Hello guys, today we talk about the crural hernia in infant. Crural hernia is protrusion, bulge or projection of an organ or a part of an organ through a weakness in the body wall that normally contains it. The contents of the abdomen are pushed down from the crural canal. Classification and types of crural hernia. Firstly, is a hernia crural reducible? Secondly, is a hernia crural irreducible? Third is hernia crural obstruda. Fourth is strangulated crural hernia, and fifth is incarcerated crural hernia. Anatomy. The crural canal lies below the inguinal ligament on the lateral aspect of the pubic tubercle. It is limited by the inferior inguinal ligament, the pectineal ligament on the back, the lacuna ligament medially, and the lateral crural vein. Signs and symptoms. Many cases, the femoral hernia does not present any symptoms. They usually present when they are erect as a lump or bulge of the groin, which can vary in size during the day, depending on the variation of internal pressure of the intestine. The lump, the bulge is usually smaller or may not be visible in the prone position. They may or may not be associated with pain. They often present with a variable degree of complication ranging from irreducibility through bowel obstruction to frank gangrene of the content bowel. The incidence of strangulation in the crural hernia is high. Frequently, it has been discovered that a crural hernia is the cause of an unexplained obstruction of the small intestine. The obvious finding may be a lump in the groin. The urge to cough is often absent, and you should not rely solely on the diagnosis of crural hernia. The lump is more globular than pear-shaped bulge of the inguinal hernia. Most of a crural hernia lie below an imaginary line drawn between the inferior superior iliac spine and the pubic tubercle, which essentially represent the inguinal ligament, while an inguinal hernia begins above this line. Diagnosis. The diagnosis is largely clinical, usually performed through the physical, objective and subjective examination of the groin, complete to diagnose femoral hernia. However, in a base fashion, image in the form of ultrasonography, computed tomography, or magnetic resonance imaging can help in diagnosis. An abdominal X-ray that shows small bowel obstruction in a patient with a painful lump in the groin does not need further investigation. Several other conditions have a similar presentation and should be taken into account when forming the diagnosis. Inguinal hernia, enlarged inguinal lymph node, crural artery aneurysm, saphenous varicella, and psoas abscess. Surgery. The type of surgery chosen depends on some factors, including the experience of the surgeon, the size of the hernia, and any anticipated complication, earlier recovery time, cost. Treatment. 3 approaches has been described for open surgery. Infrainguinal delock wood, low session strength inguinal approach, the high focus of McEvedy. Contraindication to surgical repair. Inguinal or femoral hernia repair can be performed with minimal mobility and mortality on most of patients, including those who are elderly or have medical comorbidity, example advanced liver disease. Most patients enjoy a rapid recovery to pre-surgical health shortly after surgery. Therefore, there is no contraindication for urgent repair of complicated hernia. However, pregnant women should not have elective inguinal or femoral hernia repair until at least 4 weeks after delivery. For patients who cannot tolerate general anesthesia, inguinal or femoral hernia can be repaired under local anesthesia using one of the open technique. For patients with an active inguinal infection or systemic sepsis, mesh placement is contraindicated, but groin hernia can be repaired using non-mesh technique when necessary.